I find it very fortunate today that the issues that were being handled in the residency scheme, I was looking after the residency scheme in the ministry. Many issues, when we analyze these issues that came out, around 37,000 replies that had come from the stakeholders. I think when we broadly look into it, I think mostly we can cover it in five major issues. One is, of course, the hours, the number of hours. Many of the residents, when we were looking at the residency scheme, hours was a contentious issue. But in the residency scheme of 1992, which was started by the DGHS and the ministry, I think we had fixed certain hours. So there were a lot of requests coming from our junior colleagues that this should be made mandatory across the country. In fact, there's a court case in Supreme Court, which is a PIL, which is put down by the Resident Doctors Association, that residency scheme that is there should be implemented across the country. But as that is we have certain issues regarding the health being a state subject, as we were discussing here. This becomes very tough for us to implement across the country. But as far as the central government institutes are concerned, I can assure my juniors here that the leaves of 30 will remain. I had discussed in the ministry. As far as the other institutions, and as Ojaji was saying, that this is just the minimum, that is 20, that is there. Maximum can be more. But as far as the residency scheme in the ministry is there, we are keeping it 30, and that won't change. Secondly, as far as the bond is concerned, there was a committee in the ministry. There was a under Dr. Athani. I was the member secretary there. We had all the states across the country regarding that bond. And as far as the NMC stand remains, that we are not in favor of bond. We have reiterated many times. But again, as I said, this becomes a state issue as well. And there was a meeting with all the states here with the bond policy. There were certain states like Jharkhand and Chhattisgarh who had certain reservations that the main rural the services is done by the bond students only. In fact, the word bond is very misnomer. We shouldn't call this as a bond. This is a very demeaning word, but it's a kind of a service that is being done forcibly, that we can say. But again, this being again a state subject, we cannot enforce it. But our recommendation to the ministry was that the bond should be removed. It should not be enforced. But of course, it has to be taken for the larger issues later on. Third is that there was issues about the risk hazard allowance. I think when we were looking in the ministry in the residency scheme, many of the residents had raised this issue. But risk hazard allowance, this comes under the Ministry of Finance. We had written from the ministry to the Ministry of Finance, and this comes under, in fact, the salary part component of it. So this cannot be something that can be enforced again from the perspective of the NMC is concerned. But we are taking all these recommendations that are given by you people, and I think the committee headed by Dr. Nath, he will be kind of creating a white paper or some kind of a publication. Then we will be presenting it to the ministry, and this will be a very good opportunity for the ministry to act upon it, and we will definitely deliberate upon that. Another issue was regarding the EBAS biometric system. As you know, this has been introduced this year only, and it has been introduced with a very novel kind of a perspective. As you all know, there is a lot of post faculty which are there, and we want to ensure that the quality medical education is ensured by the NMC. So this is one of the steps that's taken by it, and ministry also supports this fully. And to ensure that, one of our resident doctor was saying that the hours are not fixed. So that is why this year when we introduced it, we said just once a day is enough. I mean, once a day biometric would be taken care of. That is when we are trying to onboard all the doctors. But later on, of course, we will slowly, once these things become more and more taken up by the residents and by the doctors, we can increase for 2 also. And also, if it is taking time, we are having plans. The chairman is thinking that we want to have the facial recognition kind of a thing. There, the time period will be much less. So you just have to go there 1 or 2 seconds, it will be taken up. And maybe in future, when there's an artificial intelligence kind of a concept coming up, I think one camera can capture all the doctors or the students who are standing there, and that will be captured also later on. That was one of the issues. HRA, of course, there are issues like even in Safdarjung Hospital. When we started, we have very little hostels that are there right now. But unfortunately, it is totally landlocked, and there is no way we can grow on it. So we can think about hiring up of residential complexes. That was also looked into. nearby residential complexes can be taken as hostels for the students later on. And as far as the DRP being paid, which one of the residents had said, initially that was there and it was to be used in incentive, but whether it's to be how to be implemented again, because there's a financial component involved there, so that can also be looked into there. And one thing I think many of the resident doctors used to come and talk to me was against the violence against the doctor also. I think you people missed it. But since I'm past president of the RDA, so I can tell you that was also one component that is there. And in the ministry, we had taken up with the Home Ministry there for the violence against doctors. That act is with the Home Ministry, but there are certain issues because other professions also want similar kind of things. So there are still talks going on that. So I think being from the other side, I'm sitting on the other side of the stage right now, but a few years back I was the RDA president myself. So all these issues, I can assure you that I can take it to the NMC and our board here. Everybody is very supportive of all of you people, and hopefully in future we will be able to implement most of your issues. And as far as anti-ragging is concerned, yes, ragging is one major aspect of medical point, but in our times, ragging, if it is done friendly way, many times it was our seniors who used to teach us, but if it is done in a very sadistic way, then it becomes a problem. And that's where the issue comes, how to differentiate between what is a positive kind of interaction, what is a negative kind of thing. But I think your inputs, ma'am, will also be taken into account, and all these things will be put forward to the ministry. And I thank all of you for coming here.